All right, everyone, welcome to part two on this great interview that we have with Pete Kelly. He's a clinical psychologist at the Ottawa Institute of Cognitive Behavioral Therapy, if that's the right term.
You got it. You got it.
It's a long term. Anyways, thank you so much for being with us. This is very interesting. So this is part two. So we wanted to start part two by asking you, what's your success stories or the biggest success stories you ever saw with clients at the clinic, and who are your main clients in general, the people that you see the most?
Okay, so I think what I'll do for that, I mean, I'll give you some sort of, kind of generic patterns. I just want to be careful with confidentiality. It's hard to speak to these things with any sort of specificity, but I've had a number of clients over the years with severe obsessive compulsive disorder who have been not able to leave their home for, months at a time, or really have an, very severely impacted quality of life. And through their hard work and using the strategies, especially what we call exposure response prevention, where we expose them to the thing that they're fearful of, we prevent them from doing their response, they're able to get over the fear that they have of the fear that they have, whether it's contamination or a bad thing happening or things like that. And it can be very dramatic. So you can see people have very low quality of life, ultimately really flourish. I also really enjoy doing trauma work, which we talked about in part one, where you see people come in very guarded, extreme symptoms, hypervigilant, always looking over their shoulder, not trusting others. That kind of work takes, it can take a long time, right? Sometimes 2-3 years of weekly therapy in order to get people to the place where they need to go. But man, it's so rewarding to see clients on their way. It's extremely gratifying when they're able to sort of reinvent their life as the adults that they should be, as opposed to the children the traumatized children that they walked in the door as, basically.
Yes, wow. That is amazing.
So to be able to work with clients, they have to be willing to work on themselves, right? Do you have clients that are resilient and are stuck in their patterns, and whatever you do, they don't want to get out of it, or it takes time?
Yeah, absolutely. So there's a number of clients that come in for whatever reason, they have sort of low motivation for change. And, there's some techniques that we have. One of them is called motivational interviewing, where we try to work to bring the person around to making the kind of changes that we feel could help them, or more importantly, align with the goals that they express. The difficulty is that, it's really hard to be a human in many ways, right? And I'm sure I'm preaching to the choir here, but I think one of the biggest conundrums is that, it's like there's a starfish, an alligator, a monkey, and a human all trying to agree on where to stop for lunch on a road trip, right? Like we have all those kind of entities in our brain. So for instance, there's a part of us that wants what's going to feel good 30 seconds from now, but there's also a part of us that wants to do what's good for us 30 months from now. And they're always in a tension with one another, right? Yeah. So oftentimes what we see with clients who have difficulty changing is that they have trouble inhibiting impulses to do what is going to make them feel good in the next 10, 20, 30 seconds, right? To stay in bed, or to avoid sending that text, or not go to the gym. That can be very difficult to overcome because it works. Like in the short term, it relieves the anxiety. It relieves the sense of being overwhelmed. So there's a lot of headwinds that we're fighting when it comes to change with clients. Ultimately, at the end of the day, to make a long story short, I really put that responsibility back on the client, right? It's like, they're your goals. It's your life. I'm here to help you. I'm a consultant to your life, but I cannot fix these problems for you. I need you to take full responsibility for changing your life, because no one else can do that.
I agree. Absolutely.
So you say that people that come to you, they decide to make that move when their life hurts more than the potential benefits of changing, right? When it switches from, let's just say someone with substance abuse, when they start having problems, say they end up in jail, they lose their work, whatever.
Yeah.
Right.
It starts to be worse than the pleasure they were getting from the drugs and the alcohol or whatever. So then they would make that switch, right? Is that
exactly rock bottom? Is basically.
Is that the same with like mental health clients? Like when they start hitting certain, like they lose their relationship, they lose their work, then they come to you, right?
Yep, it's pretty clear that it's the perceived loss associated with symptoms as opposed to the symptoms themselves that tend to drive people into therapy, right? So exactly when relationships when relationships start to fall apart, when you start to get a bad performance review at work,
Yes.
when your friends start to give you feedback that you're, not very pleasant to be around, that's what will drive people into therapy. Yeah, that's what the data suggests.
Okay. What in your experiences that has been, let's say, the mental illness that was the hardest to work with? Would it be like a bipolar disorder, borderline personality disorder, schizophrenia? Sorry.
That's a great question. And it's actually really complicated because I guess there's two layers to it, right? So there's some clinical presentations which are notoriously challenging. So I would say, for instance, what illness or health anxiety, which used to relate to hypochondriasis, right?
Okay.
Or that disorder is renowned for having sort of very poor insight associated with it. So that's where clients will believe that they have stomach cancer despite reassurance from their doctor, or having a number of diagnostic tests done, things like that. It's very difficult for those clients to believe that they're okay. Same with another disorder called body dysmorphic disorder, where someone may believe that their nose is, horrendously big and ugly, or that their muscles are too small, or that their face is asymmetrical in some way. Okay. It can be very difficult to help those clients because their insight is very low and their ability to reality test is quite impaired. So they almost have there's almost a delusional quality to the thinking. Now that said, I've had many clients over the years with very severe symptoms who are actually just, lovely to work with, right? So that's the other layer, right? Is that there's the problems that the person has. There's also the interpersonal style that the person brings to therapy. And some folks are more, they're easier to work with than others. Clients who come in, say, with like a narcissistic personality disorder, that's typically not a presentation that goes very well from a prognostic perspective, right? There's lots of, it's difficult work. There's lots of barriers that get thrown up. Interpersonally, it can be quite a challenge. Mm-hmm. So you do what you can. You remember that the person didn't ask for that brain. That there may have been childhood factors or family dynamics that influenced them to develop that interpersonal style. We always want to remain within a compassionate, empathic frame to how that person came to be. But that doesn't change the fact that their prognosis may be poor, because it's very difficult for them to sit in the office with you and to listen to the advice that you may want to give.
Mm-hmm.
Okay.
No, absolutely. I agree. Right?
Yeah, no, of course. So
I just want to say one thing real quick too, because borderline personality disorder comes up a lot in those kind of conversations, right? Yes. Yes. I have clients with borderline personality disorder who are, the easiest pie to work with. It's never a problem. We get along just fine. Good therapeutic alliance. Use the strategies. Partner with me at all times. There's other times where I have clients with that same diagnosis where it proves to be very challenging and it can be difficult. So even within a diagnosis, you get a lot of variability in terms of how people present. And I always try and just remember that the person is trying their best. Their best may not still be serving their, what's in their best interest, but they are trying their best. I always try to remember that.
Yes.
And in regards to that, because that's something that we're touches us personally on our family side. So, what would you say causes that, or what's the biggest challenge with someone with borderline personality disorder in their day-to-day life?
So 80% of the time, someone with borderline personality disorder will come from an environment, an at-risk environment, right? Where there's trauma, typically emotional neglect, things of that nature. So if you look at a lot of the symptoms that go along with borderline personality disorder, they really comprise a toolkit for managing chaotic, neglectful family environments. And those coping strategies make a lot of sense within the scope and context of that early family environment. They don't make a lot of sense, or they're not particularly effective when they're dealing with healthy, well-adjusted, securely attached people. And that's where the problem happens, right? So it makes all the sense in the world in that family of origin. It doesn't make sense outside of it. And that's where those folks end up struggling. That's where we, as I alluded to before, that's where we help them to unlearn those patterns to be more effective in their day-to-day interactions with people.
And if we elaborate on that, the patterns would be, for example, what? Like if we cut for people, because I always try to get on the podcast, we have the smartest people and we have the ones that we say borderline personality. I don't even know what it is, right? So,
right.
try to get in between that range.
So, some of the patterns that you'd see with borderline personality disorder would be sort of a pattern of chaotic relationships, right? Where it's very emotional. There's a lot of ups and downs. There's what we call splitting, where someone with the personality disorder may play two people off one another. You can see a lot of idealization where someone's like the best person ever, and then subsequently the very next day they're turned into the villain by that same person. So that's a process of what's called idealization and devaluation. So that's another pattern. There can be interpersonal manipulation. There can be a lot of impulsivity around substances. Clients with borderline personality disorder can be prone to having, let's say, a lot of sexualized experiences. There can be a lot of difficulty with emotion regulation, increased self-harm, increased incidence of suicide and voicing suicidal ideation, suicidal gesturing. It's again, like it can be a challenging presentation. But I always try to remember it's most challenging for the client who's going through it, because imagine, experiencing those things.
Yourself, how horrible that would be,
Right.
So for those clients, the experience within their brain is very real. So they go from being happy to being very moody are they aware of what they're doing? The people or to the environment? Are they self-aware?
So a lot of times initially no. And that's where, if you've heard of dialectical behavior therapy, which is DBT, that's the main, I would put that under the rubric of cognitive behavioral therapy.
Okay.
DBT is typically used for clients with borderline personality disorder. That's what it was developed for, and to help keep them safe because of the high risk of self-harm. What DBT does a really good job of doing is emphasizing mindfulness and mindful awareness, right? And there's this idea of wise mind in DBT, where you've got your emotional mind, you've got your rational mind, and you put them together, and that's what's called wise mind. So what you want to do with clients with borderline personality disorder is to help them to get into that wise mind perspective, where they're both paying attention to the strong emotions that are there, but they're also leveraging that rationality part, that rational part of their brain, and together they get the wisdom, right? So that's a skill that is really necessary to build and to help them to get curious and mindful about their internal state instead of acting on those impulses, which can be extremely strong.
So basically dissociating themselves from the emotions, seeing it and trying to understand and rationalize it instead of
acting on that and then.
Right. And so there's a lot of, so for instance, a common technique in DBT would be emphasizing, do you want to be right in this situation or do you want to be effective?
Yeah.
Right. So, and it's all about, what are your goals? Yes, the person is being rude to you. I know you want to get mad at them. What would actually meet your goals here? What would be effective in the long run in terms of interfacing with other people? It may not be yelling at them, right? It might be smiling, nodding, saying, I appreciate that that's your take. We're going to have to respectfully disagree. I'd like a refund. Thank you very much.
Mm-hmm.
So when you say they're initially not aware, and what do you mean by that? So when they react strongly to an emotion, they don't understand. So when are they aware?
So there's often, they may not even be aware of the emotions that they're feeling precisely. So one of the first steps is to start to get people to start labeling their emotions.
Okay.
It's like, oh, I'm feeling jealous. I'm feeling sad. I'm feeling despondent. I'm feeling anguish. Like having a really high resolution description of their emotions, because if you can't measure it, you can't manage it, right? So that you want to get people to start, and then labeling the physical sensations, again, leveraging a lot of those same CBT sorts of things, like what's going on in all those different parts of the model.
Okay.
And then putting it all together and then getting people to narrate what's going on, right? I'm having the thought that, I'm having the urge to do the following. Mm-hmm. I am feeling this or that, because once you get people to start to name, it's like name it to tame it, right? You name all those different pieces, then you can start to use the appropriate strategy to address those different pieces of the puzzle.
Okay.
Yeah.
So if we go back to CBT, when was it invented, and how did it become some sort of like a broadband practice for different mental illnesses that like help people cope with that? Right.
So the original, if we go back a little bit, you had Freud, who started off with psychoanalysis, right? Yeah. And Freud actually had quite a few amazing insights. He got a lot of things wrong, but we take that for granted now. But he got a number of things right. You then had Carl Jung. Then the behaviorists kind of came on board and they said, hey, wait a second, like BF Skinner, things like that, right? Just looking at stimulus response type learning. And from there, there's a thought, okay, well, maybe thinking counts as well. So then you had the sort of father of cognitive behavioral therapy is Aaron Beck. And so he developed this CBT model originally, I believe, for severe depression, actually. If you read one of his original books, I believe it's for treating severe depression. And then from there, the field has really grown. So you've got your sort of standard CBT. I think maybe one of the best examples of that, if people are interested, is the book Mind Over Mood by Christine Podesky. Okay. That's sort of like your classic CBT kind of workbok. But then there's other things too, like there's emotion-focused therapy, there is dialectical behavior therapy, there's acceptance and commitment therapy, there's mindfulness informed CBT. So from that original CBT has sprouted a whole range of other interventions.
Yeah. So is that all different services you offer at the clinic, what you just mentioned?
Yep. So yeah, we have DBT groups that we run. We have a CBT stream where we have these really manualized protocols where people would do a mind over mood or Michel Dugas' protocol for GAD or insomnia, very protocol structured therapy. I do a lot of what's called schema therapy, which is pretty integrative. It's a combination of like CBT, psychodynamic, attachment theory, things like that. I do a lot of acceptance commitment therapy as well. So do other folks in the practice. There's some of us who emphasize mindfulness more. Often it really boils down to the clinician's sort of wheelhouse and preference in terms of what they offer.
Wow. And do you do a lot of mostly one-on-one work, or do you ever do things as a group? So you get a lot of your patients that come in and discuss each other's stories, just because a lot of us, right, people feel better when they know that they're not alone. You know what I mean? They're not the only person that deals with these types of things.
Absolutely. Yeah. So we do offer a lot of groups for anxiety, depression, core beliefs, things like that. DBT, amazing. Like I mentioned, I totally agree. The group dynamic is really important. And that the cohesiveness and that ability to identify with others is a real active ingredient in someone getting better and knowing that they're not alone, just like you said. So we do therapy in both group and individual. Our group therapy tends to be more cost effective for people because we can spread out the cost over more people. So for folks who have, we know time and money doesn't grow on trees, and therapy is pretty expensive. So we try to grade out our services in a way that makes it accessible for different folks depending on the resources available to them.
Wow.
So someone that has insurance with psychology services covered, you would be able to plug that through the clinic, right?
Yep. So what we do is that we ensure that we have psychology heavily integrated into all of our services, so that at the end of the day, the services are ultimately supervised heavily by psychology, and thus the billing is able to flow through insurance in that way.
Okay.
And we're certainly not we don't believe in that model of sort of like a therapy mill where, there's one psychologist and 20 people that work under them. And, we don't like that at all. So we have very close and tight supervision of all our cases. We have wonderful occupational therapists that work with us who are highly trained in CBT. They're able to develop and deliver services in a really cost-effective way, but in a really rigorous way, and that's supervised by psychology. So yeah, we're trying to be honestly, we're trying to just be really innovative in the programming that we offer. Okay. And part of the programming that we've developed is really to make up for services that just don't exist in the community, frankly, and to alleviate some of our own frustrations where to refer people. So we've just built the services that don't exist, to be totally honest, and really to be self-serving.
Online, you're like the only one that came up. Basically, it was hard to find this kind of services around.
Yep, there's other good practices out there as well. There's Anchor Psychological Services, Gilmore Group, CIFR. Just to be fair, so other folks know that they're out there, and others which I haven't mentioned. But no, we really do pride ourselves on being innovative and really trying to bring CBT to the masses in whatever way that they are able to consume it, given their resources and where they're at.
Yeah, okay. And you offer services online, right? Would you offer services to Americans, let's say, because we have some listeners that are from United States, if they can do it like we are doing right now, a Zoom interview?
So there's a matter of some debate about this. Technically, the most conservative way to view it is that the person has to be residing in the province that you are practicing in order to be able to deliver that service.
Okay.
So most of us, I would do, again, it's funny, the whole COVID-19 situation has really brought that. So a lot of us, for instance, like we're in Ottawa, we have a lot of clients who live in Gatineau.
Yeah.
Yes.
And,
exactly.
So the question is, even though they're in Gatineau, they can't leave their house. Through Zoom, can they come see us? And I believe the answer is, the college in Quebec has said, it's like if they're in Zoom, they're traveling to see us in the province. So it works out. Anyway, not to get too much in the weeds on it, and I'm kind of, I'm speaking about things I'm not totally familiar with, but typically what we do, just to be clear, is we try to see people within the province that we practice in, because that's where we're licensed. So that's the way it's got to be. Yeah.
Oh, okay. All right. Well, that's why I'm asking for our listeners.
Yes. Great question.
Yeah. Has access to your services.
Also,
right?
as far as age range goes, what is the youngest patient you've ever had?
So myself, the way that our regulatory body breaks it up is there's youth, child, sort of adolescent psychology, and then there's adult psychology, and then there's geriatric psychology.
Okay.
So myself, I would see people between the ranges of 18 and 65.
Okay.
Below that, I would refer them to someone who has a competency in child and adolescent psychology. Above that range, I would refer them to a colleague who has a competency in so-called geriatric psychology.
Okay. Amazing.
Yeah, so this is good for people to know.
Field of course, absolutely.
Yeah, because sometimes people, I'll have friends of the family say, "Hey, are you able to see my daughter? She's 16. She's struggling with depression." I'm like, unfortunately, I'm going to have to refer her to another psychologist who has that competency. We tend to be careful about seeing friends and family members, because we have this principle of what's called dual or multiple relationships, where it can create conflicts of interest.
Yeah.
It can be very tricky, especially dealing with confidentiality. Like, say, for instance, if you guys had a child and I was seeing that child and I was friends with you, what if they were having a problem with you? Would they be able to feel like they could speak freely with me about what's going on? So we tend to really steer clear of any kind of situation where there's any conflict of interest. If a friend of the family calls me up and says, "Hey, can you see so-and-so?" I will almost 100% of the time redirect them to another psychologist so that it's free and clear. We don't have that conflict laying over top of it.
Okay. Yeah, makes sense. Absolutely.
No.
So I wanted to get a little personal about my journey with depression, because I think that's something that a lot of people in their surrounding, especially it seems to be, at least in this day and age, a lot of people are dealing with family members or people that are depressed, right?
Sure.
So in my journey last year in 2019, so I started having a lot of stress at work. She was experiencing the same, and the mix of both, because we work in the same workplace. So it was amplifying everything. We started, losing sleep, being stressed at work, bringing that back home, started drinking. Then drinking got me to getting caught with a DUI. And it was all the court thing of fighting that. And then my dad committed suicide, right? So all those circumstances together, they plunged me into depression. And it was a very sneaky thing, because at the beginning, it's not like it hits you right away. It's progressively hitting you more and more,
Right.
And one of the thing is, eventually I lost interest in everything I was doing. I had no energy, like just brushing my teeth, making breakfast, getting out of bed was really hard. So,
however, you still did it.
Yeah, well, I still did it because I kicked my ass to get out of bed and do stuff. But it was very hard, and it was very horrible in the way that what I was feeling was very real. So, and from a CBT standpoint, you were saying that you break those patterns. CBT, standpoint, you're breaking those patterns of getting people like you're feeling depressed. So do something that a non-depressed person would do, right? So for the longest time, I tried different things. I tried new activities. I was going out, doing different sports. I bought a bike. I started bicycling and just doing different things to get me out of the house and being more active. I would get a boost of well-being when I do the activity, but the moment I stop, I plunge back into depression.
Right.
And I would get overwhelmed very easily. So it was very hard for me to manage, and especially for her. She didn't know what she was dealing with. Who's this guy that I'm married with? So, so then I started trying Prozac. It got me into the state of being kind of like a zombie, and then I had no sex drive and everything. So I guess my question is, from a CBT standpoint for people with depression, what would be your tips? We talked a bit in part 1 about changing those thought patterns. So I had experienced with Prozac, and I tried Wellbutrin, that got me out of it. But so go ahead. Let's talk a bit about that. For people with depression, what do you suggest?
No, for sure. So Matt, first thing I want to do is just applaud you on, on your vulnerability and sharing that story. And that sounds like you had a very difficult, year. It sounded it was about a year, that you were contending with that.
Yeah, that's what got us to start this podcast. Seriously, I was off work because I couldn't, I carry a firearm at work, so I couldn't get work anymore. And I needed to keep busy, right? So I started wanting to share and help people and bring more knowledge and insight. So that's why I'm super happy to do this interview with you today.
Yes.
Oh yeah, no, I'm happy to be here. And again, I applaud the courage, and we need more people sharing their stories and talking about this kind of thing. Mm-hmm. With respect to your question, so with depression in particular, I tend to take a very behavioral approach, because often if you reflect on your own state back then, when we're depressed, it's often difficult to connect with things cognitively being better, right? Like it's hard to imagine that, things are going to get better. We might feel hopeless. Our motivation is going to be really low. Mm-hmm. Oftentimes the thing that we have the most control over is our behavior, right? Mm-hmm. So my military clients have a great saying, like, you don't have to feel like doing something to do it, right? If they tell you to get out there and dig a ditch at 6 a.m. and it's pouring rain, you don't have to feel like that doing it to do it. You just do it, right?
Yes, exactly. You just don't think about it. You go and do it.
Well, because they yell at you too.
Right.
I'm ex-military, so
Okay, yeah. So you know the drill here, right? No pun intended. Yeah. And the I have another little saying that I use with depression is trust your schedule, not your motivation, right? Okay. Because the thing is with depression, if you remember that mood loop that I talked about before, I
lived it, so I know. So I was
right. So if in depression you wait for your mood to get better, so then you might be waiting a long time before you do something, right? So I often have clients come in, they're like, well, when I'm feeling a little bit better, I'll go to the gym. I'm like, no. It's actually going to the gym that's going to make you feel better.
Yeah.
So
that's right.
So your ass and going.
That's right. Yeah. So with depression, it's a lot about putting the cart before the horse, right? You've got to do the action or the behavior that the person, sorry, let me just turn off my email here. It keeps clicking.
No problem.
You've got to do the action or the behavior that the healthy version of you would do, even though all of your mood is screaming at you to not do it. It won't be worthwhile. Who cares? Why, it doesn't matter. Yeah. Why bother, right? Yes. So and this is where mindfulness can also be helpful too, because people can train themselves to it's like, oh, look at all the depressed thoughts I'm having. I'm having a thought right now that this won't be worthwhile. I'm having a thought that this will be worthless. I'm having a thought that, it's not going to be any good. It's not going to go well. But ultimately, if you just do the behavior, that speaks louder than words, quite literally.
Absolutely.
You generate new outcomes in your life. You get new data, and you can start to overwrite all the old thoughts and behaviors that are coming up. And then you can get a different outcome. So I like to leave thinking out of the equation with depression, because often people can't see past their thoughts when they're depressed, right?
Yes,
so it's just like, listen.
That was my situation.
Right. And you can't, a lot of family members say, oh, just snap out of it, or, pull up your, it's like, okay,
exactly.
oh, sorry. Right. It's like, oh, sorry, I forgot about that part. Thanks for the reminder. So it's really about just doing what the non-depressed version of you would do, and then trusting that will pull your mood along. And let me say one more thing about this.
Yes.
It's really important. What the trend is now is to couch all of that behavioral change in the context of values. And values are things like your romantic relationship, being a good parent, being a good friend, recreation, being part of a community. So what I get people to do is tell me, how important are these things to you? How much of your behavior is going into those things, and where there's a big gap between how important you're saying that part of your life is and the amount of behavior that's going into it, that's where your depression is going to live. And what you need to do, your job is to start to design a whole bunch of behaviors and activities that are going to fill in the gap between what you're saying is important and what you're actually doing, right? Because it's not enough just to talk. You've got to live out the things that are important to you, and then your brain will generate a sense of meaning, and then the motivation will come to pull you forward.
Okay.
Don't you really?
Oh, I want to say one more thing too about depression.
Well, I want
to say one more thing about depression and motivation.
Yeah.
Everybody thinks that motivation happens first, and then you do the action. It's the exact opposite. You do the behavior, then the motivation flows. So if people who can't get started, just do anything. If you can't get to the gym, get on a 5-minute walk, and then you'd be like, oh, you know what? That went better than I thought. I'm now motivated maybe to do a 20-minute walk. And then 20-minute walk turns into the treadmill, turns into a 5K, turns into you're doing auto or race weekend.
I
right?
absolutely agree.
Yeah, you've got to do the behavior, then the motivation will come. If you're waiting for motivation, you might be waiting forever.
For a long time.
In my experience, that's what it was. I didn't have any motivation, and it wasn't coming. And people relate to their emotion and state of mind, right, most of the time. So if they feel a certain way, they act and do everything in accordance to how they feel. And I think that's very important what you're mentioning, because I remember I wanted to close my pool, and for 3 weeks I was just that I had the thought, I have to close my pool. I have to close my pool. I have to close my pool. And one day I just said, okay, today my goal, I wake up, I close the pool. And it wasn't something hard, but in a depressed state, it was so difficult to get out there and just disconnect the pump and do all the little stuff that you have to do before winter.
That's right.
By doing it, then I felt better after. I was like, all right, it's done. So I didn't have those thoughts every day that I have to close the pool anymore because I did it, right? So
that's right.
Yeah. So when I started doing more things, like you're saying, that's when I started being better. And I think what really got me out of it was when I really accepted that I was in a depression. And I really, because, coming from the military, our ego and stuff, I didn't want to be labeled depressed. I didn't want to have a label. And I was fighting it for the longest time. I wasn't even honest with my psychiatrist I was seeing as part of work. I had to, see a psychiatrist and stuff. And when I started being honest, that's when it really helped. But I remember I even wrote her a letter because she didn't understand. So I had to say, listen, this is the illness. This is not me. I'm fighting it. I'll get better.
Right.
Bear with me, And in respects to that, what would be your tips for family members that are dealing with someone who's depressed?
Yeah, that's a complicated one in some ways. I guess I would say the following. There's got to be some balance between supporting the person in addressing their illness, but also not becoming codependent and self-sacrificing.
Yeah.
Right. So you'll often see situations where you've got one spouse who's depressed and then the other is sort of trying to prop them up, and then they start neglecting their own care. Then they get angry, resentful, or depressed themselves. And then the whole situation just starts to unravel. Right. So that was our case. So we get and that's listen, guys, that's such a common pattern to fall into. Right. And you have to, be compassionate with yourselves about thinking through that. I think boundaries are important for the spouse, right? Where it's not acceptable for the person to lie on the couch all day. It's like, hey, listen, I know. So for instance, I would have a conversation like this. Yeah. I know that you're depressed and that you're doing your best. What would be feasible for you to do? Maybe it's like, can you get the kids' lunch ready? That's all I'm going to expect of you. But if we agree that's what you're going to do, then that's the minimum that you do.
Yeah.
Right. You can't cut the person a blank check and just say, okay, well, you just lie in bed all day.
Mm-hmm.
Yeah.
Because that's going to enable and facilitate and accommodate you're going to turn the person into an invalid. Right. And human nature is just such that if you're allowed to get away with things, you will, because we all do that. Right.
Absolutely.
Yeah. If someone showed up in my house and did the dishes and took the groceries out, or got the groceries and took the garbage out every day, like, where would be my motivation to do it myself?
Right.
You don't need to. It's taken care of.
No, exactly right. So boundaries are really important. And I think that can help turn things around when the depressed spouse realizes that, okay, like, I've actually got to get motivated and moving here. Because also the other person might say, the worst case scenario is, because no relationship is unconditional, no matter what people say, right? Everybody has limits. You can be pissed off sufficiently with somebody in your life that you decide to leave.
Yeah,
right.
Absolutely.
Right. So there may be a point where the person says, listen, I'm not putting a timeline on it. I'm not putting a date on it, but there's some invisible line in the sand that we're going to cross at some point where I may decide that being here is not consistent with my own mental health anymore.
Yeah.
And I need you to this is what I need to see you doing in order to make me feel comfortable about staying here and frankly feeling safe for my own psychological well-being. Mm-hmm. So it's a give and take. Like, we have to be compassionate that the person's struggling with a real difficulty, but that doesn't mean that the other person has to neglect what they're going through and their needs in order to self-sacrifice for that other person.
Yeah, it's really, really well put, in the sense that that's what we experienced, right? I was taking responsibility for what I was going through. I was kind of waiting for her and waiting for motivation to come and her to help me out. And, for the longest time, and nothing was changing. Every day I was just, the same and the same and the same. And
right.
when I changed those patterns, that it
changed everything. When I wrote that letter and said, listen, enough is enough. I was in that state for like 8 months before I started getting out of it. So it was a rough 8 months for her. And, as you can say, for me as well. But I mean, for our relationship, right?
Sure. Yeah. Yeah.
Yeah.
Did you want to go in depth about also now your withdrawals with your medication?
Yes. So medication, we want to talk a bit about that, right? So I tried Prozac to help me up because my doctor was like, okay, well, we can maybe try some no medication or something. Like I was saying, Prozac really made me like a zombie. I was just sitting and being content and happy with everything, but I wasn't happy with who I was in that state. So I don't know from your experience, but in my experience, medication changed who I was. I wasn't the same person. And
is that very common, Dr. Kelly?
Yeah, it's a mixed bag, right? Where some people report that medication makes them more themselves, right? They're like, oh, this is the person who I remember being.
Wow.
I have other clients, though, who report that, they're like, I don't really care about things as much anymore.
Yes.
And typically the more that you increase serotonin, that it antagonizes dopamine, and you get a reduction in dopamine. And this is where sometimes you get the sexual side effects, things like that. This is why Wellbutrin's prescribed, because it increases dopamine.
Yeah.
Okay.
So you get that. So yeah, it's a real mixed bag.
Okay.
I'm going to say this just because I feel like I need to say it as a psychologist.
Yes.
Officially, according to the College of Psychologists of Ontario, we have no official expertise around medication. So, I'm speaking to this anecdotally just as a practicing psychologist, but for folks listening, really your family doc or psychiatrist is your go-to, maybe the pharmacist as well. But I can speak generically to these things, but I just want everyone to know I have no specific training or expertise in this beyond just what I pick up doing the job. That's all.
Okay. All right. Yeah. Following on that, you were talking about Wellbutrin. That's what I was taking afterwards when Prozac didn't work. And that because it increases noradrenaline or norepinephrine, whatever, I started having more energy. So that really gave me a kick to start, getting up and doing more chores and being more active and whatnot, which was great. But at some point, I find it wasn't serving purpose anymore. So I got off of it. I've been off of it for 2 weeks, but the withdrawal side effects were horrible. Like I had crazy headaches. I was just feeling really tired and whatnot. And I guess that might be why people have a hard time getting off the meds, because I don't believe that you need the meds all the time, or do you?
Well, here's always the problem, right? When with any particular client, there's only one of them, right? We don't have a clone of them that we could run an experiment where we're like, okay, well, who's going to do better, the guy with the medication or the guy without? Yeah. And also same with dose, right? Like, so where there's just a sample size of one, it gets really tricky to know what's doing what. And even if sometimes if clients get better, it's not even clear that the medication's working. Was it just the passage of time? Mm-hmm. Was it the therapy that they did? Yeah. It's hard to know sometimes. Those withdrawal symptoms can in particular be quite challenging for clients, especially, some drugs are renowned for this more than others. Effexor is one that typically seems to be pretty hard to get off of, from what my clients tell me. That the benzodiazepines like clonazepam, Ativan, diazepam, those are renowned for being notoriously difficult as well. There is some evidence that some people just don't seem to be able to get off like an SSRI, that they need to stay on a very small dose for life. Otherwise, they have lots of problems with their mood. So that doesn't seem to be the majority, but for, rightfully so, some people are skeptical or do not want to try medication because they are afraid of some sort of dependency forming, right? Yes. Not an addiction, but like almost like a physical dependency at a neurochemical level.
Yes.
Yeah, that's what I felt. But, I don't even know if it's the meds that got me out of it or just me starting to be more active and doing more of the stuff I used to do.
That's the thing. We just never know, right? There's only one Matt. So if we had three of you, we could run the experiment, but, we often don't know what's going on.
Yeah. Well, now that I stop, other than the withdrawal, I don't find them any different. I'm not relapsing into depression. I'm not sad when I wake up, So hopefully it stays that way. That's the goal.
Yeah. Yeah, if you keep all those healthy habits going, right, then life tends to work both snowballing up and snowballing down, right? So success and stability tends to beget success and stability. So the more that you're doing what you're doing, the more that you're consolidating that improvement.
Yes. Mm-hmm. All right. Well, we're gonna have to wrap this part 2 of the interview.
Yes.
Okay.
Thank you very much.
If you have time, we'll go to part 3 and maybe talk a bit more and wrap it up. If you're okay with that, if you have the time.
Yeah, I'll have probably about 20 more minutes, 25 more minutes.
Perfect. We'll take them if you give it to us.
Yeah, for sure. We'll do it.
All right. Okay. I'll see you there.
Yeah. Okay.